We're going to be talking today about optic nerve tumors. And by optic nerve tumors, I'm going to be focusing in on primary optic nerve tumors. And the optic nerve really doesn't have a lot of stuff in it. So it can make a tumor out of the nerve itself, and that's going to be a glioma. Or it can make a tumor from the sheath, and that's going to be a sheath meningioma. So the two most common tumors of the optic nerve are optic nerve glioma and optic nerve sheath meningioma. And we can differentiate these based on clinical grounds and also on radiographic grounds. So the optic nerve glioma is usually a younger patient, in fact often a child. And what we're worried about is the associated phakomatosis, neurofibromatosis type 1. So you're going to be looking for the cafe au lait spots, the axillary freckling, the Lisch nodules, and the other cutaneous findings of neurofibromatosis type 1, the neurofibroma. A child with an optic nerve glioma is going to present with optic nerve findings. Those are the usual optic nerve findings: loss of acuity, loss of field, relative afferent pupillary defect, a swollen or a pale optic nerve, but the nerve might be normal. Because it's orbital optic nerve glioma, we would be worried about proptosis and ophthalmoplegia. So a painless, progressive loss of vision is the stem for optic nerve glioma. We're going to be looking for the optic neuropathy findings, RAPD, and a pale nerve. You're going to think about NF type 1. And the imaging of optic nerve glioma is typically a fusiform enlargement of the nerve itself. So it's an intraaxial, intraparenchymal enlargement of the optic nerve. And so an optic nerve glioma makes a big optic nerve. Obviously, if it's intracranial, it'll do the same thing. In the chiasm, it'll be a big chiasm, and it can even be in the optic tract. In contrast, the meningioma is not usually a child, although meningioma can occur at any age. It's typically an adult, usually an older-aged or middle-aged female. It can be associated with multiple meningiomas or the schwannoma of the eighth nerve, and that's NF type 2, neurofibromatosis type 2, even though most patients with sheath meningioma do not have NF type 2. And just like the optic nerve glioma, similar types of clinical presentation: painless progressive loss of vision, RAPD, swollen or pale optic nerve. If the nerve compression is slow enough, they might have a shunt vessel, a retinal-choroidal venous collateral that is shunting the blood from the choroid, venous side, and the retina out the optic nerve. And we might have orbital signs, proptosis, ophthalmoplegia, just like with the optic nerve glioma. The optic nerve sheath meningioma has a different radiographic feature. So it's in the optic nerve sheath, and so it causes a tram track sign. So the sheath itself is enhancing and enlarged, but the parenchyma of the nerve itself is usually not, although there's some variability. So if the enhancement and the enlargement is in the sheath, they're an adult, we're thinking about sheath meningioma. If it's intraaxial, intraparenchymal, fusiform in a kid, especially with NF type 1, we're thinking about optic nerve glioma. So the two main primary optic nerve tumors that you need to know about: sheath meningioma and glioma. Similar clinical presentation, different demographics, different phakomatoses, and different radiographic features.